Honorable discussion, dear audience, good morning. This is Dr. Atikur Rahman from NICBD, a stone grinder in Cathlab. Mr. X, 74 years old, hypertensive, diabetic, non-smoker patient, admitted through emergency department in NICBD with complaints of chest pain for 5 days. On examination, all vitals are within normal. AHS troponin I is slightly raised. ECG, ST&T changes in anterior precordial leads. Echo, anteroseptal wall hypokinesia, fair LV systolic function. Previously, he was diagnosed as a case of non-STMI and underwent CAG 1 month back. CAG findings are TBD. So my diagnosis is non-STMI, diabetes, hypertension, and history of TBD. So we plan for coronary angiogram. This is right panel. Right panel shows there is significant lesion in proximal RCA and diffuse lesion in PD and PLB. Left panel shows left main is within normal. There is significant lesion in LAD proximal, LCX proximal, and diffuse lesion in distal lesion. Syntax score or 31. So discussion with the patient about pros and cons of the procedure. We plan for PCI strategy. And we plan for a stage in PCI at first RCA. Through transradial approach, JR6 fans and floppy wire is negotiated. Pre-IBUS run from RCA, distal to proximal. It shows there is calcified lesion, concentric calcium is present, calcium thickness is more than 5, and calcium length is more than 5. MLA shows 2.81 millimeter in proximal RCA. So we plan for rotablation of the patient in RCA. Before doing rotablation, OCT is run in RCA. OCT shows there is concentric calcification, thickness is more than 5 and length is more than 5. MLA
with multiple interventions and surgeries. I want to go in a different way. Actually, I want to go in step.
So we started with rotabar. Rotabar is 1.5. In our Cathlab, it is the highest bar. 1.75 was not available at the moment. So 1.5 bar is introduced. Short ablation run of 15 to 20 seconds is rotated. A speed 140K to 150K. This is post-rota IBUS in RCA. Calcium crackles is seen. Calcium breakdown is present. MLA shows 3.1 millimeter square. Then we tried for pre-dilatation with 2 by 12 NC balloon, but unfortunately balloon tapping and dog boning is present. Balloon is trapped. As there is 1.75 bar was not available in our Cathlab at the moment, then we plan for IBL of the patient in RCA. This is post IBL run in RCA. Calcium breakdown is seen. At last, extension is done. Giants expedition 3.5 by 48. Post dilatation is done by 4 by 12 millimeter quantum apex NC balloon. PD is going on. This is final shot of RCA after rotablation and IBL, rotatipsy. Rotatipsy. Rotatipsy is the combination of rotational atherectomy and intravascular lithotripsy for the treatment of severely calcified lesions. In balloon uncrossable calcified lesions, rotational atherectomy is the first-line modality to enable operators to advance balloons and extend over the stenosis. If the lesion is undilatable after rotational atherectomy, a hybrid approach with additional intracoronary lithotripsy can be effective approach that further modifies the calcified plaque and enables stent delivery. So, rotatripsy can represent a valid therapeutic option for undilatable, heavily calcified coronary artery lesions. I acknowledge Professor Mir Jamaluddin sir, Director and Professor of NICVT. Thank you.
Thank you very much for your presentations.